to introduce somebody who many of you will have met before and heard speak before. She just happens to be my doctor, but I'd like to welcome to the stage Professor Claire Harrison from Guy's and St Thomas's in London. She is also a clinician, obviously. She's a researcher, and she's also a very, very passionate supporter of patient advocacy. As you heard from Maz's talk earlier, she was inspirational and extremely important in the establishment of the UK patient support group. So, Claire Harrison.
Well, thank you very much. How wonderful. This is your 4th meeting, and it's growing all the time. It's really great to be back. I thought you were going to say I was an England rugby supporter. I was watching the score partly on the plane and partly in the taxi, and telling him that we won. Yes, we beat New Zealand. In my house, it's going to be a big problem if we have to play Wales in the final, because my husband's Welsh. So, wonderful talks from Martin and Stefan, and good to see this community growing stronger. So I've been asked to talk about guidelines for MPN, and I make this first statement. There are no standard guidelines across the globe for MPN. You can decide if you think that's a good thing or a bad thing, and we'll explore some of the differences. But I also wanted to particularly point out where some of the interface between patients, their families, advocates, and also the clinical community, not just doctors, also Yvonne, who's one of our team, also here, just trying to think about the multifaceted way we should bring up guidelines. So there are a lot of guidelines. I didn't say there were none. There are lots of guidelines for MPN, and there are a variety of them shown on this slide. Probably some of you have guidelines. I'm sure you almost certainly do in your countries. They can be very useful, and I've listed some of the ways in which guidelines are useful on the slide. In theory, they help us to standardize treatment, but of course a guideline is only a guideline. It's not a protocol, and that can be a good thing and a bad thing. You can choose not to follow it, but it just indicates what the standard direction might be. It's very, very useful for education. A lot of our trainees and new staff will look at guidelines, and a lot of medicine now is focused on guidelines. What should we be doing? Now, partly that's because of medical legal practice being sued, thinking about, well, what would be standard practice and measuring yourself against that. But also it's really important around better use of health resource. That can be helpful because it can be linked to reimbursement. I put a question mark next to that. We tried really hard recently to get ruxolitinib reimbursed in the UK for PV patients, and even though it's in our guidelines, we didn't get it reimbursed. But it's still about saying what we think evidence-based standard of care should be. And it can also be useful in pointing out areas where we should be doing more research and potentially endpoints for clinical trials. And I know you've got some discussion about clinical trials later. So we have some guidelines in the UK. They're hosted by the British Society of Hematology. They have an app and a website. And in the MPN setting, there are a variety of different guidelines. And we've had them since about 2005, actually. We first wrote the guidelines for PV in the same year that the JAK2 mutation was discovered, so we immediately had to rewrite them all again. So we have guidelines for the 3 main MPN. We recently revised our guidelines for PV, and there are some very tricky diagnostic situations around PV. I don't know if any of you with your members have come across patients who think they've got PV, but they haven't. They've got a high hemoglobin, and that can cause a lot of stress for patients. Importantly, the UK guidelines recently revised a threshold for high risk from 60 years to 65 years. Nothing to do with the age of the clinicians writing the guidelines, all around evidence. but we do make changes. We also have guidelines around rarer entities. These don't often get an airing in these meetings, but maybe they're important amongst your membership. Hypereosinophilic syndrome can be a really devastating condition. It's in the MPN family in the WHO book, and it can be very difficult to diagnose and manage, so we've written a guideline on that. And we also have some diagnostic approaches, and guidelines can be helpful in allowing us to be able to test those mutations that Martin explained so beautifully, because testing for them can be very expensive, so about resourcing and when you should be using them. So in Europe, we have a kind of pan-European body called the European Leukemia Net. We also have the European Society of Medical Oncology. We're very fond of 3- and 4-letter acronyms. Stefan showed you the ESMO guidelines, but the more recent European ones are the European Leukemia Net guidelines. They've added some new things, new criteria for diagnosis, but these are just assimilating the World Health Organization criteria, lowering the threshold for thinking about a diagnosis of PV, addition of when we should be using these wider genetic tests, who should we be testing. They've brought forward the equivalence of interferon. You heard about Stefan's patient being treated with interferon. Probably many of you have got experience with that drug. And in the past we had said, well, we think hydroxyurea may be better, but now the current guidelines are actually saying they're equivalent. It's the same in the British guidelines. But there is dissonance or disagreement between some of the guidelines, which is interesting because it probably reflects a lack of, that things in the medical literature are balanced. But you also have to remember who's written the guidelines and who's been involved in them and what their influence might be. So, for example, the ELN, we weren't sure about the use of ruxolitinib in myelofibrosis, and some of us were arguing very strongly, Stefan, I remember, for its use, and some not. So, for example, these are the ESMO guidelines. You saw this before. In the ESMO guidelines for low and intermediate risk myelofibrosis patients who may be symptomatic, ruxolitinib and conventional treatment are equal, but in the European Leukemia Net guidelines, they suggest hydroxyurea first. In America, they're a little bit behind us, I would say, in terms of writing guidelines for MPN, and they launched the NCCN guidelines for MPNs in 2016. And these were the guidelines that they had at that time. They were around diagnostics and treatment response, disease burden and treatment planning, and then they have revised their guidelines recently and included guidelines again around mastocytosis, another very rare condition, and eosinophilia, as we already touched on. So NCCN guidelines were specifically in my title, so I'm just running through them a little bit for you. They talk about the workup, and then they break treatment down. They recommend using WHO, they recommend using a symptom tracker, and I think there should be a strong focus on that amongst the clinical and patient communities. And they recommend using the newer molecular markers for prognosis. We could discuss how you can use a different prognostic tool and come up with a different prognosis for patients. That's not actually mentioned in the guidelines. How do you actually manage that when you sit with a patient in your office and you put their criteria into one of these scoring systems? Yvonne and I recently did this, and one said a patient had 25 years, another said a patient had 16 years. So trying to put that across quite difficult. The NCCN guidelines, if you get to look at them, are really nicely written, actually. They're written in a way you can easily pictorially understand. So they're suggesting here, here's the risk, you assess the burden, then you decide is the patient symptomatic or not. It gets a little bit more complicated, of course. But I think these are really very nice and very easy to follow. We're quite fond of writing great big loads of text that can be easily misinterpreted, but I really, really like this approach. And there are other groups that write guidelines as well. So in Eastern Europe, which is a huge amount of land and a huge amount of people, they have different guidelines. And for example, this can lead to different treatment choices for patients. So I'm just going to show you an example of that, quite similar actually to Stefan's presentation. So in the European guidelines, most of us would just recommend for patients who are low risk with ET, age less than 16, no blood clotting event, platelets less than 1,500, just watch and wait, and nowadays using the molecular markers, we're sometimes asking, well, would we even give aspirin or not? And for high risk, we would give hydroxycarbamide or hydroxyurea with aspirin. Interestingly, the Czech guidelines, or the SEMPO guidelines, are a little bit different. So if you looked at a clinical case, sorry about that typo, 45-year-old this time, CALR positive patient, quite similar again to Stefan's patient. Platelets not at the threshold, so this is a low-risk patient. What treatment? British NCCN, ESMO and ELN would say aspirin only, but the CEMPO guidelines would say aspirin plus a Microlight or interferon. And actually they're not wrong. It's just a consensus-based approach in that community. So I think it can be confusing, and we need to kind of navigate a way to manage that. This is the data about aspirin. Here showing that although currently we recommend aspirin for all our patients, the CALR positive patients, apologies if you can't see it at the bottom of the slide, we saw a lot more bleeding if they were treated with aspirin versus if they weren't. So we need to revise our guidelines around that subject, and we haven't yet done it. It's not reflected actually in any current guidelines. So now I want to touch on some things that are actually missing in guidelines that we could perhaps try to bring forward, or just to illustrate the fact that you can't have a guideline for absolutely everything. So if you happen to be a JAK2 positive patient with ET and your hemoglobin starts going up, it can be in the normal range, but it can be at a threshold where if you happen to have PV, your doctor would be saying, I think you need to go and have a phlebotomy now. So we haven't yet sorted out in our clinics, I'll be interested to hear what Martin and Stefan say about this, what do we do in this situation? Because the driver gene is the same, the diseases are very close together. Should we be making all these patients iron deficient and making them spend a half a day more in our clinics? Another important point, often not covered in the guidelines, we would say, switch the therapy. Switch the patient if they become intolerant to hydroxyurea, they get mouth ulcers or leg ulcers, to this. But we don't say how to switch it. So that's a cause often, I think, for all of us, of a lot of people calling us up. And it's a really high risk time for a patient. How to manage children with MPN is another area not well covered in guidelines. And I think it would be useful to have a focus on what do we do about young people. And the European Hematology Association Strategic Working Group, which many of us are members of, which could do with some patient representation actually, has been focusing on young people. So disadvantages of guidelines, other than the gaps, they may not be up to date. The JAK2 story I gave you earlier on was a great example of that. They can encourage formulaic practice. The guideline says this, therefore I will do this. Stefan's patient, the guideline says I should treat you with interferon, even though you feel terrible. It may not reflect locally available therapy or practice. Another example, often given, people who live at high altitude may have a higher hematocrit. They need it for oxygen delivery. So you have to be careful when rigidly applying guidelines. But overall, I think the balance is in favour of advantages, but they could do with being more dynamic, a little bit more patient-focused, in my view. So what are our current efforts around guidelines? Of course, they're ongoing. They remain relatively region-specific. Our current collaboration in the European Leukemia Net also includes American investigators, which I think is helpful. I think we should be thinking about lobbying for MPN advocacy to be involved in guidelines, to try to put the patient perspective. And maybe we should be translating them into something that's a little bit more patient accessible, and that's where I think the NCCN guidelines are very good. So I want to end there. Thank you very much.
Thank you, Claire. So now we've got, let's see, a fair bit of time for some questions to all of our clinician speakers this morning. So I'd like to open it up to the floor. So who has the first question for any of the doctors who have spoken in the last 45 minutes or so?
I have a question to Claire. If we consider that, I'd say basically every patient reacts different. We know that if you talk to 10 patients, they all have their own story. Isn't it then very difficult to put a guideline, having so many different inputs from the different patients?
Sorry, can you just clarify your question? Is your question how would we include a patient in a guideline process if a patient has a different process, thought experience?
Yeah, I'd just say, how can you make a guideline if basically every patient has a different, he reacts in a different way to medicines, or he has different symptoms? Werner, he should go to the sun and for his pruritus. I cannot take the sun, so it's sometimes completely contradictory.
So the guidelines, that's a great question. We write a guideline in several ways. We write it based on medical evidence. So the balance of opinion is if you take 800 patients with ET and you give half of them anagrelide and half of them hydroxycarbamide, most of them will do fine, but hydroxycarbamide seems to be a bit better, so we would prefer to use that drug, but we don't rule out the other one. Guidelines often would include, for example, a host of different treatments for pruritus. So it's trying to include everybody, but also to give non-expert clinical staff an idea about what the evidence base is and what the expert community feels is best. It's not about being rigid. They absolutely should not be rigid. Stefan, did you want to say something?
Yeah, maybe I can add. I think we're very limited and bound by the clinical studies that have been done, because they typically include patients that are young, don't have many other problems, other comorbidities, and then this is really difficult to transmit this to the clinical practice. So this is what we try, and then we have these guidelines, but of course we need more data to really guide a specific patient, and that's, I think, why we need these clinical experiences, real-world experiences, your experiences, and also registry data to inform us better on treatment decisions other than just freestyling.
So can I come back? I completely agree with you that actually some of our best data comes from real world. What we mean by real world is that we just collect data from our clinic, your clinical practice in Aachen, or Martin's in Tel Aviv, or mine in London, and we look at how do the patients do. And that's much more real world. It's not what's used to licensed drugs usually, but it is what's used for therapy. But I think having a patient involved in writing a guideline or a patient advocate is also another way of putting that across. Sorry, John.
I think that's a pretty good answer. But one thing I would say is that we know that the vast majority of MPN patients are not lucky enough to be treated in centres like yours or Martin's or Stefan's. And the question therefore would be, if your own decision making is not only informed by the guidelines, but by your own personal knowledge of your practice and your patients, how does that knowledge get disseminated to non-specialist hematologists in other centres?
Okay, thank you. So sorry, we do include that information in the guidelines. But unfortunately, the best grade of evidence comes from randomized placebo-controlled trials. They are not always, one, reflective of the main patient community, nor two, actually very fair on the patients who took the placebo pills. So we do include, for example, that graphic I put up about calreticulin positive patients bleeding more with aspirin. That's actually from about 20 centres across Europe, just putting in our data. I think there is something about experience and knowledge in managing patients, though, which you just can't get over. It's really very difficult.
Maybe I can add. So what we do is we have once a year, we have an annual meeting of all the centers participating in our MPN registry, and of course it's open for any physician, where we try to reach out and discuss cases. We frequently discuss cases on the phone also, but what I found very interesting also is that patients, educated patients and advocates as you are, they inform the doctors quite a lot also, and that's a very good sign. So we should try from every side and every angle to increase knowledge about and experience about these diseases.
Werner.
In the morning, we asked what the MPN patients' advocates could do. Claire, would it be a help if we would collect all the guidelines and put it on our website? I learned this, till now I only knew two guidelines, the German guideline and the NCCN guideline. Yeah? But there are so many different guidelines, or would it be confusing if we would collect it on our website?
I'm just shocked you don't know about the British guidelines. Werner, terrible. Right, so I think, well, they're not so very easily digestible as the NCCN guidelines. I think it could potentially be a bit confusing, because I think knowing where to go to get information is important, knowing that you host accurate information, that for a patient at a time of stress and uncertainty, going to a website and finding lots of different guidelines and then being sure that they're really up to date is a challenge. I don't know, Martin, whether you want to say something.
Well, I understand what you're saying. I think that certainly at the outset it would be very challenging for patients. However, once you're into the process and you might want to compare and contrast what you've seen or been exposed to, it might be more useful. And certainly having international membership of an MPN group such as this, it might be more fair perhaps to provide more resources. They could just be in the form of links, for example. You don't have to have the entire document present. I do acknowledge that some of the guidelines are more easily digestible than others. That is true. And that would be something to work on, perhaps maybe making the all of the guidelines sort of visually and easily understood by patients, by their caregivers and so forth, might be a way forward for this as well.
Yeah, Felice.
I think, in my opinion...
Microphone's not on, Felice.
Oh, okay. In my view, the guideline is not only for patient, also is especially important for physician to give recommendation. When I don't find a unique guideline, I suppose the physician don't know what they do. And I am, unfortunately, I search for a second, a third, a fourth opinion, because you say something, the guideline say for you, the other guideline for Peter is different, for Stefan is different. This is not. Then the patient involved is to reduce to translate in patient language the guideline, but it's important the physician sharing the guideline, because otherwise I am not guaranteed to have the right treatment, the right, for example, it's important to to do the test for mutation or not test for mutation, at initial or when I am symptomatic, when is right. This is the general line. After, I know the real world data is totally different from the clinical study, but the general view is important to have. It's not possible to have each people in the guideline the right response for each one of the patient, but it's important to have the consensus about this way.
Maybe I can answer. I completely agree with you. I think there is a high need, at least in Germany, where we don't have only MPN centers, but we have lots of office-based hematologists and oncologists throughout the country. And they are also using these guidelines, the German guidelines, for various diseases. And I myself am also using them. For example, if I have a patient with a specific lymphoma, to guide myself whether this is the correct treatment or should I contact someone who's really an expert in that area. And I think your question about should we put out all the guidelines for patients, really it depends on the patient. There are patients of mine that I discuss these guidelines more intimately than with, let's say, a local doctor, because they're so very well informed and they want to know. And other patients say, well, it's okay if I have one guideline and you explain it to me why you're recommending this or that treatment. So I think, again, it's more complex than just one answer.
I'd like to add something to that, which is actually very, Stefan said something very similar to what I was going to say. Just to give you my perspective, I work in a country where we have no local guidelines for certainly MPNs or a lot of the other hematological diseases that we treat, and that's deliberate. We've reviewed a lot of the guidelines and decided, apart from translating them into a local language, we don't feel that we have much to contribute in terms of adding or subtracting from the written guidelines, even though they are different in some important areas, for example, as to when precisely you would use cytoreductive therapy in patients with essential thrombocytosis, as we saw. And in order to write your own guideline, you have to really have something which is evidence-based or data-based to contribute and to make that change. So apart from translation, which is what we have done, we've not added anything. And just going to what Stefan said, I think it's important to acknowledge that in medicine in general, and certainly in hematology, things are becoming so complex. We're sitting here talking about 3 or 4 diseases over 3 or 4 days. There could be another 10 different groups of hematologists talking about their diseases which they focus on to the same depth and the same level of intensity. So it becomes really impossible to get a good handle and to be able to be an expert in everything. That's as, say, academic hematologists who are in university hospital type practice. If you then go one step further and look at community-based hematologists, or in the United States look at oncologists who will be treating breast cancer, lung cancer, colon cancer, and polycythemia vera all on the same day or in the same clinic session, you can see how difficult it could be for somebody to get a hold of everything. And I think those are the physicians who need to refer back to the guidelines just to get their sense of equilibrium and balance, and then, as Stefan said, identify that they have a lacuna in their knowledge which needs to be filled by perhaps consulting with a local expert or somebody abroad.
So I want to say that in the UK, the British guidelines, they're actually the most downloaded articles from the British Journal of Hematology. So they usually are the most popular articles, particularly the MPN ones for some reason. I don't know why. I just wanted to comment about what might a patient advocate add to the guidelines. I think that would be very helpful to bring the experience of the patients into, where some of the difficulties might be and some of the narrative that could be there in the guidelines. Something maybe about measuring symptoms, something maybe about the benefit of patient advocacy, etc. could be helpful.
Yeah, Dave.
That's what I thought. Thank you. So I have a question regarding the different mutations and treatment related around those mutations. I asked my doctor for one of the detailed gene screening tests, and he essentially told me that it may or may not be covered by insurance, and he said, I'd hate for you to get stuck with a $2,500 bill. And beyond that, more importantly, he said, we would not necessarily know, based on the different mutations, how we might treat you differently. In my case, I'm in CHR, using a combination of ruxolitinib and Jakafi, and I actually brought that treatment to my doctor after seeing that presentation at ASH in 2015, and so I think it's an excellent therapy. But that being said, can you tell me, are we there as far as understanding those mutations, or am I okay to just say, well, I'll wait and see?
Okay, well, I'll try and answer that. I think just in very general terms, within the MPNs, I think we have the most amount of prognostic information around patients with myelofibrosis, particularly primary myelofibrosis rather than secondary or progressed PV or ET to myelofibrosis. So we think that we know how to begin to approach patients with one of the high molecular risk mutations in primary myelofibrosis. That may not be the case in myelofibrosis that's developed out of polycythemia vera or essential thrombocythemia, because that's not quite the same as primary myelofibrosis. Regarding polycythemia vera or essential thrombocytosis, the high molecular risk mutations or the passenger mutations in general are not that well understood in terms of their prognostic significance in terms of those diseases. And they would not be used to make treatment decisions. I think really treatment decisions is a euphemism for allogeneic stem cell transplantation, which is, I think, the crux of the question. So if you had a patient with primary myelofibrosis in whom you knew there was one of these high molecular risk mutations, particularly at a high frequency of mutation, a term referred to as a variant allele frequency or VAF that was high, which implies a large number of cells or a large clone of cells which actually carries this mutation. We know that those patients may develop a more aggressive form of disease and transformation to acute myeloid leukemia. The difficulty comes if you have a patient in whom the prognosis is intermediate, say a decade or so, and you knew that they had one of those or more than one of those high molecular risk mutations. That would imply that their prognosis is worse using the more modern molecular-based prognostic scores. So in a sort of a form of trying to be a prophet of sorts, you would say things might not work out that well for you. Let's try and cure you of your disease using allogeneic stem cell transplantation. The downside obviously being the toxicity, including a mortality risk of that procedure in someone who's otherwise healthy. Very difficult decisions. We looked at those Kaplan-Meier curves. Somebody who has a bad Kaplan-Meier curve to start off with a prognosis of between, say, 1.5 or 5 years, the decision is somewhat easier because the prognosis is bad from the outset and you need to do something drastic to cure a drastic situation. On the other hand, people with a very low prognostic score who have potentially decades of healthy life in front of them, one would not want to engage in risky medical procedures such as stem cell transplantation. So the intermediate group would be a potential group in whom having one of those high molecular risk markers could change your management from being a more conservative drug-based therapy to a more drastic or aggressive stem cell transplantation-based strategy. I think that's where it would come in.
Maybe if I can add something, I think it's becoming clear that we don't know much, right? Every day, I think we're learning more, and we learn that we don't know a lot. So one of these things is that we know that there are these mutations, and we might know the prognostic impact. We also know that patients should be given a certain treatment, but then as Claire has shown, even with aspirin, or we have similar data for interferon, it can matter which kind of mutation you have. And I'm just saying that we need much more basic research and clinical research to find out which patient will profit the most from, and even from which dose of treatment. So we need much more research, I think.
Yeah, question here.
Well, it's more of a comment on Dave's question, is that I don't know how treatment decisions could be made on these things unless you get the information in the first place and that the physicians can pool it. I know that my doctor is doing exactly what, I was going to make the verbatim comment that Dr. Ellis did, that somebody who has the ASXL mutation with, especially if they're relatively young, and they have primary myelofibrosis, they're going to get recommended to go for the stem cell transplant right away. Whereas, like, I don't have that mutation. My doctor told me, let's wait for the sweet spot. We want to wait until you're sick enough that you need it and it's worth the risk, but you're not so sick that you won't be able to withstand the procedure, right? So I think that they have to collect all that information. And I know Dr. Gupta in Toronto he has a fellow, a medical fellow in hematology, who that's all he does. That's his entire thing, is mapping out all of these mutations that are of unknown significance and looking at all the patients over time and trying to get all the information from across Canada so that they can make new guidelines, at least for countries. I know it's really difficult to share across countries because of the privacy, but that's what we really need as advocates. If we could do one thing, I think would be to try somehow to get de-identified information with just this genetic information to be able to be pooled, because it's such a rare disease. I think that there has to be some way for the physicians to share that kind of information. If you just do it in each center, each country, you're just not going to have enough information, I think.
So I wanted to make another comment. I think that was very articulately and well put. I think we do share information. So actually the data for the calreticulin aspirin, just as a simple example, that came from many different countries all across Europe. And a lot of collaboration around this kind of information is really, really critical. I also just wanted to add that mutations are not everything, right? So you can have the best mutational profile, but if you smoke and you don't exercise and you're overweight, you are not going to do well with your disease and you're not going to have a stem cell transplant. So it's really important that I think the mutational score that just looks at genomics and chromosomes is so wrong. And the final thing was, this is a new medical specialty, so it's really important about how the result is interpreted, how sensitive it is. And this ASXL1 mutation, I have a boy, he's 17, he comes from Gibraltar to see us. He has an ASXL1 that was called a mutation on a gene panel, but actually it's not a mutation at all. It's just what we call a polymorphism, part of the normal variation in the DNA. So this is something that medical experts have to learn to interpret as well.
Robbie, go ahead. Not yet. No, it's not working. Speak loudly, Robbie. Thank you very much. Rob.
I want to mention a very important point that I see. I believe that the relation between the physician and the patients is also very important, because from my experience that I am a PMF, primary myelofibrosis patient, diagnosed for almost 9 years, we have the normal meeting with my physician, and we are discussing all the impacts that we have, the behavior of the symptoms, etc., the blood counting, etc. And I have a full record of the historical diagram of what the symptoms are going, and blood counting, everything is going. And then she advised me if it's the way, is the time to begin some treatment or not. See, we are working according to some rules, but in any case, everything is slightly open. It's not an exact mathematics that you can say exactly what to do the next session. No, we arrived to a session that probably maybe in the next 2 or 3 months we have to decide, or we have to decide together if I begin a treatment with something, with interferon Pegasus or whatever, because maybe it's something that slowed down the disease. But that's what I want to say. It's very important to maintain good relation and not only relation, but understanding and belief in your physician that she's doing the best and we're doing the best, and that's exactly what we want to do, like MPN advocates, to empower also the patient itself to be a part, to take part and responsibility of this of his treatment. Okay.
Take it away. Try it.
Yeah.
It should work.
Well, I don't know if it's going to work.
Working.
Yeah.
It's working.
Hello. I would also like to say that it's very, as he said, that it's very important to have a good relation between the between the patient and the doctor. But sometimes it's quite difficult, especially when you visit a local hematologist, which is not MPN specialist, and then you have to ask for a second opinion, third opinion, and you have to travel, and then to have a consensus between the MPN specialist and the local specialist, because sometimes the local specialist, which is not a specialist in this matter, don't want to admit that he's not a specialist. So in this case, it's really hard to.
Can any of the doctors on the panel here relate to that situation?
Absolutely. Maybe I can start. So I think the main advantage I see in having centers caring for specific diseases is the time that we can spend with an individual patient. So for myself, if I see a new patient, I have 1 hour to really spend with him or her to discuss the disease, while the local physician may have 5 minutes. So, and I think that's why we do need these centers. And then it totally depends on how I interact, of course, with the patient, but also with the local doctor. I frequently call them up because sometimes they don't want to talk, they don't want to call us, or they don't have the time, but it's really important to talk. And then even one phone call can change a lot. So you could encourage your doctors to communicate with each other, and the advocates can help a lot in boosting this.
Thank you. You've been very patient. Time for one last question.
Sí. Yeah.
Yes, excellent. I have a really brief question to Stefan. You mentioned the hydroxyurea and the young patient problematic. And in Finland, we have this national guideline that if you are under 60 and you need cytoreductive therapy, it's always interferon. And if you are over 60, it's always hydroxyurea. And we don't have access to interferon anymore. So all the patients are now changing to hydroxyurea. So I really want to know more about the leukemia risk on that one, because our patients are really worried about this situation now.
Yes, thank you very much for the question. I think this highlights a lot of points which need to be addressed by all of us. First of all, I think the Nordic countries were very ahead of everybody else in recommending pegylated interferon for younger patients. Of course, we are lacking solid data, but we have to advise these patients. And so I think there's really consensus across the world now that young patients, especially young women that want to get pregnant, should be treated with interferon, at least for a while. And the basic problem is that it's not reimbursed in every country. And I think it's sad to hear that now even patients are being put back on hydroxyurea, even though they may have been doing well on interferon. Of course, there is a new interferon that's been licensed in the European by the European Union. So hopefully this will pan out for these patients. On the other hand, I don't want hydroxyurea to be perceived as a bad drug. I think if there is an indication for such a treatment, cytoreductive treatment, I always tell my patients it's much better to take hydroxyurea than to not take anything, because that's solidly been proven. That I think is a good answer. There might be a slightly elevated risk for leukemia, but it's really hard to quantify that risk, and it really depends on the previous treatments and also how long this is taken. So my answer would be that we need more studies and more medications that we can choose from. But if you have to put them back on hydroxyurea in a patient that needs cytoreductive treatment, then this is clearly better than not treating this patient with cytoreductive treatment at all.
Can I say another drug that is forgotten here is the Microlight, which is also available, which is for ET, which can be helpful for patients. But there is an issue about interferon and its availability. And we do have Brasemi, which is the new
AOP orphan are here
AOP,
today.
Yeah. And the data for that is really, really great, but we only see it approved for PV. Many, many young patients actually have ET, and many patients with ET are women. So we're really hopeful that there can soon be studies and approval for the AOP drug. Who's clapping? Somebody? Excellent. Okay. Yes, good. It's really, really, really important. But I think also it's maybe time that we stood up and asked that some effort is made to keep at least one, if not two, interferons, because we know that some patients will tolerate some interferons better than others. So we really applaud the job of the MPN Foundation in the US, who's been really advocating for this and lobbying Roche. Many of us have also been trying, and I missed your conversation, so sorry, I won't prolong it.
Okay, that is just about it. All the time we've got for this particular session. Couple of housekeeping things before I thank the panel. The first thing is that Lydia's pointed out that up in the lobby there is a list of the transfer times to the airport for you tomorrow and Monday, and some extra time has been allowed for travel on Monday morning because uncertainty about the traffic, so make sure you check your transfer time. And the second thing is that we are planning to have a group photo now upstairs in the lobby. So if once we've finished now, could we all make our way upstairs as quickly as possible, and we'll all have our photo taken. So with that, I'd like to thank the doctors who've joined us on the panel this morning, and I think they've done an amazing job as usual. So one last round of applause for them, please. Thank you.